So hi everyone, and welcome back to this discussion. We had a wonderful discussion with Alpesh last time, and there were like probably 5,500 views, which was absolutely crazy. And that was one of the reasons why we actually are doing this live stream again. Um, Also because there were so many questions that all of you had regarding how to restart practices, etc. So that's something that we're going to discuss today. What we're also going to discuss today with Alpesh is the HFEA self-assessment document, which he was so kind to share with us. So we're going to talk a little bit about how he actually went through the process. And Alpesh, hi, congratulations for getting the approval from HFEA. It's absolutely fantastic, and I was very sure that you would be able to get it. But today you're going to discuss how we in India should actually go through with all of these requirements and what are the precautions that we're going to take.
Thank you so much, Keshav, and absolutely a pleasure to participate in your webinars, in your lives. I am pleased that yes, we have got approval. We were one of the first clinics in the country to get the approval through this. And I think what gave me the capacity to be prepared was having pre-prepared this for a while. This doesn't happen overnight, and you've seen yourself from the intricacy of the document that there's a lot to prepare. There's a lot of documents to create, a lot of risk assessments to have, etc. So we were in a very fortunate position that when the authority opened the invitations, we presented our responses the same day, simply because we had it all pre-populated and we had the documents ready. So as you know, the UK framework is one of the toughest regulatory frameworks in the world when it comes to regulation. And again, anything such as the COVID pandemic, no one has been prepared for it. Of course, this is a globally a challenge for everyone. But we all know that we've had to come up with new processes, new procedures, new testing methodologies, new risk assessments that can actually enable us to offer treatment in a very safe and effective way. And I believe that if one prepares to open up using this self-assessment questionnaire, it really is a very robust system, and embryologists and clinicians would have really made sure that they have thought about every possible avenue before starting up. One of the things I'm hearing, Keshav, I had a very interactive webinar yesterday with some very prominent embryologists from India. And one of the things that has been shared is that clinics are opening up without knowing the implications of this. They're actually using the same procedures that they used to. There is not awareness about precautions, PPE, what methods they should be using. Now, this is dangerous. And I think to a certain degree, it borders on the verge of irresponsibility. There is so much of good practice guidelines available now globally through various many societies, as we've discussed before, namely ESHRE, ASRM, BFS, ARCS. All of these have really issued very comprehensive guidelines on how clinical activity should resume. So no one has the excuse of not being able to implement these good practices. And I appreciate that you guys are in a very different economic setting as well, in terms of costs of IVF. Everything that we are potentially going to be talking today is not free. It costs money. And I take that on board. But really, there is some very key messages here, which I hope embryologists can benefit from so that they can prepare better to safeguard themselves and their patients.
Yeah, that's absolutely true. And I was also I also saw these posts on WhatsApp today, and in the last few days, that a lot of IVF centers are starting, especially the areas that have been deemed as green zones. They are the ones which are starting up. But we have to now understand that we have to take precautions. WHO says today that you have to now live with the virus, but how to live with the virus, nobody's talking about. and that's something that we have to discuss today. So thank you so much, and once again for actually coming on board and discussing this. I think this is much needed in our country, and hope we have a good discussion today.
Thank you. Thank you. So, if we move down that COVID self-assessment questionnaire, firstly, and of course, you've got the template, so please feel free to share this with
Yeah.
anyone who's interested on your side. But maybe if we just go through the questions, and you'll see that we have had to issue evidence as to how we have answered that question. So here we are. First question is, have you recorded the risk assessments undertaken to identify risks arising from the provision of treatment services during the COVID-19 emergency and the mitigating actions taken in relation to each risk to ensure staff and patient safety? Now, this document in itself took me a couple of weeks to do because it's just to answer this question, you have had to comprehensively think about every process, be it clinical, be it admin, be it laboratory, because all this question is so generic and it encompasses everything.
Can I interrupt you here, and can you just enumerate like a few of these risks that we're talking about, so that people have more clue of what we're actually discussing today?
Sure. So, the typical risks being, if you identify the admin level, is your triaging. How are you triaging? Are you triaging on site, which is essentially not really effective because your patient is already on your doorstep and potentially may have brought the virus in. So you need to really either do a telephone triage beforehand, or you need to do a electronic triage whereby the patient sends you the triage form 24 hours before attending the clinic. So that is one risk potentially. Clinically, of course, testing. How are you mitigating the risk of someone who's potentially symptomatic entering your system? So, you would cover things like, all the testing that you potentially do. We have adopted a system whereby we're testing each patient twice. We are doing an IgG test at the beginning, and when they're having their consultation or just at the beginning of the journey, and we are doing a RT-PCR test for current infection on day 8 to day 10 of their stimulation. So that is our protocol. Now, in the laboratory, the risks are obviously different. There's a lot of risks we don't know about. We know so much from the last time we spoke, which has really changed the tune of how we would actually manage these risks. Now we get told that the testes shows the receptor, the ACE2 receptor. We've been told that the embryo also has been demonstrated to show this receptor. We know that the egg doesn't have this receptor, but this potentially opens another level of risk that if these receptors are present, then any virus that is in your culture system will potentially incorporate into your gametes, in your embryos. So things are developing so rapidly, Keshav, that the conversation we had 2 weeks ago may have changed also now. And this is what I'm going to tell, that a risk assessment I did 2 weeks ago, I've had to update that. So this is just to kind of give you some examples of what a thorough risk assessment is.
Yeah. So I'll just take a second here. So the first question basically tells us that during this period of lockdown, when we are all locked down in our own homes and we're not going into clinics, I think it's our sole responsibility to start creating SOPs for the risk assessment policies that we have for COVID. And we should be utilizing our time to actually identifying all of these risks and how we mitigate them. So I think that should be the first message for all of us here.
So again, this question is very clear. It's very broad, but it's also very clear. And the highlights of this question are, mitigating actions, which is very important because that's where you have to demonstrate what mitigating actions you're taking as a clinic. And secondly, identifying the risks. So those are the two key parameters that this question really needs to have answered. Moving on, does the risk assessment also apply equally to your satellite and transport partners? And again, if you're working with other clinics whereby patients are being stimulated elsewhere, but they're sending you patients on the day of egg collection, then you need to also assess and elaborate this risk assessment to those practices too, because the patient is having shared care. So you can
So
move
all
that.
your referral centers have to have like a triage system. All your referral centers have to take precautions and then only accept those patients in your clinic.
Yeah, and again, I know there's a lot of debate, Keshav, about testing in the Indian scenario. There's a lot
Yeah.
of discussion about, are these tests accurate? What is the sensitivity of these tests? But look, some action is better than no action. And I think we have to work with what we have. I appreciate that a cost of a test is around 4,000 rupees. But again, this is some, in the UK we have no option. And sometimes, Keshav, the blessing of having regulation and regulatory framework is as such that it binds all of you in the same thread. It doesn't leave subjectivity into what you would do and what the guy next door would do. And I
That's
think this is where I feel that it would be great to have that level of regulation come into govern fertility clinics in India.
But like right now, we don't have any guidelines, and by the time the guidelines comes, hopefully COVID will be over. And but the thing is that we have to keep preparing for the next pandemic to hit, or because this is now something which has to be there in our systems because this has happened to us in our lifetimes. We have to prepare for the next one, and all the things that we do right now are actually to ensure that such scenarios don't happen in the future. And that's something that we have to focus on, because if an IVF lab is working without any regulations at the moment, if we're not taking any precautions, we can actually be spreaders of the virus, which can be more harmful for the
Absolutely.
patient.
And
So
trust me, in the US, there are lawsuits that have started around medical facilities who
yeah.
have supposedly passed the virus on. So, we just have to work with good practice guidelines. And again, going back to that question number one, everything that we spoke about last time in terms of the personal protective equipment, how your lab practices need to be modified in order to, minimize risk, how your embryo transfer procedure, because you need to try and minimize the number of patients coming in, any people who are accompanying. You need to also, discuss things like going paperless, your triage protocol, your deep clean. Everything falls into this question number one, which is mitigating the risks.
So can I ask you a question here? You're saying it took you 2 weeks to prepare all of this, but how many hours did you dedicate to it? Because I'm sure you've had sleepless nights over
It
this.
was crazy. I was working on this day in, day night, and luckily I'm blessed to have a compliance manager.
Okay.
Keshav is actually an ex-HFA inspector. So, I really had a great amount of help from her. But, of course, she can't do this on her own because the inputs are very clinical and scientific. So I
That's
had
true.
to feed into that whole structure of it, but we worked together tirelessly. Yes, we worked for 2 weeks non-stop on some of the main documents there. Anyway, moving on, do you have a process in place for an immediate review of your treatment commencement strategy, policies and procedures in response to any changes or updates and guidance to the UK and devolved government professional bodies? So again, question is asking you for a COVID treatment commencement strategy.
Yeah.
Again, I'd be very happy to share some of my documents if you want, because they're very elaborate. But my COVID commencing strategy is a 9 to 10 page document, okay? Because
Wow.
it covers, again, every aspect, right from patient triaging to testing to an algorithm at which points testing is going to be done, which points are going to be stopped procedures, meaning stop gaps to check that are they symptomatic, non-symptomatic, etc., etc. So
Okay.
again, this commencement strategy is also quite important. And again, let me tell you, this is also covering themselves. The HFE are very good in saying that you need to review professional body guidelines and list those professional body guidelines. Now, in my treatment commencement strategies, I've had to take excerpts from every professional body guidelines to demonstrate that I'm complying to that good practice guidelines, so to speak.
And we are now considering the ASHRAE guidelines, the British Fertility Society, the ASRB, and ASRM. These four or more, or there are more.
I tell you, we have got some excellent guidelines that have been published just last week by the British Fertility Society. Trust me, I think it is such a superior document because it is very, very detailed and very comprehensive. ASHRAE is good. I still feel that, in my opinion, there are some gaps. After reading the BFS guidelines, I feel that the ASHRAE guidelines are more generic because they have to cater to the world, whereas the BFS guidelines are very specific to the British regulatory framework, and hence takes into account how we offer IVF in the UK, and it's more specific to us. But I certainly feel that if anyone wants to have a very comprehensive read of what good guidelines should be, I would guide them towards the British Fertility Society guidelines.
Okay, so for all our viewers out here, we have new guidelines from British Fertility Society which came out a week ago, and I think it's available online. You can easily go and access them. Otherwise, I'll be sharing a link on this stream once this talk is over. Second thing that I want to say to all of you is that we are accepting questions, so you can just type in your questions on the comment screen, and we will try and answer them. Yeah, moving forward.
Okay, so obviously then we come into patient information, consent, and support. I mean, we've got 49 questions, so I don't think we're going to have time to go through everyone. But I think it's important that we go through sections because there's some 6 sections to this SAQ. So every clinic is expected to have a detailed patient information leaflet around informing patients of how their care may be modified during the COVID pandemic. It also puts the onus on the clinic to make sure that you educate your patients about the risks and the benefits. Sorry,
I'm going to interrupt you here. I think this is one of the most important points for our country as well, because this is something that can be developed very easily. This is something that you can actually take from online sources. And this is something that will actually ensure that you're safeguarding yourself as well. So because if there is any clinic or if there are any legalities which happen, you can actually show that, okay, I gave my patient patient information leaflet. These are the risks that we talked about, etc., etc. And this is something which should be incorporated in all practices. So I think first message to all viewers, create a flyer for dealing with COVID and ART and put it in your clinics.
Absolutely. So that is the patient information leaflet is the paramount document that needs to go off even before your patient attends a consultation. In the UK, they're asking us to tell patients that the advice is to wait. But if they don't want to wait, then they can go through. So patients need to know that they have the option. Secondly, consent. We have developed a special document, a consent, which is specific to having treatment during COVID, whereby patients are acknowledging that there is a lot of unknown risk. They're acknowledging that they may be potentially infectivity that may happen in the clinic because, you know, they may come across me and I may be asymptomatic.
Yeah.
So there's that level of risk that they're taking. They also know, so they sign a consent for that, and they also sign a consent for saying that if they are shown to be positive during the testing, their cycle will be abandoned. So, and then the support element just talks about that. How do you deal? How is the clinic equipped in terms of the counseling to provide support to these couples should they be found to be positive and their treatment abandoned, because that could be quite devastating for a couple. So those are the things that this section is talking about.
And this is something that we discussed last time as well. And I have a question from Gaurav which says the same, where if a patient is found positive before OPU, what should be the advice? Cycle cancellation is something that all of these recommendations are guiding us towards. And that is something that we have to tell the patient. So when you have consents in place, when you start talking about all these uncertainties right from the start, probably the patient will be more receptive towards cycle cancellation. Probably they'll be ready if this happens. We're going to do this, etc., etc. So all of these things have to be put into place, and it has to be right from the start of the cycle.
So yes, and to add to Gaurav's question, I think one of the questions he's asked is, what if a patient is found to be positive before OPU?
Yeah.
Certainly in the UK, what we would do is, if the patient has been found to be positive after trigger and before egg collection, then we would have to freeze their embryos as if we're treating a virally positive patient. So in a
So this
closed
this is
system.
after trigger.
Gee, sorry?
This is after trigger.
Yes.
But
If
what
it's
happens?
before trigger, you cancel it.
Okay.
If it's before trigger, you have to cancel the cycle.
Yeah.
Now,
Okay.
moving on, of course, this section is also talking about staff wearing PPE. And I must say that one thing I've noted, certainly just from seeing pictures of how people are taking PPE quite seriously in India, and I've seen, my brother-in-law and everyone there, they're cardiologists and from the medical background. And I see, the good thing is that I see even at the public level, the engagement with personal protective equipment is quite good. So I know that there's quite a lot of awareness of PPE, even at the public level, when visiting these medical facilities. So I'm quite reassured to know that the education awareness of patients wearing PPE is also there, and not just the staff, which I think we in the UK can reinforce that a bit better, because I don't think our people are really well educated about PPE at the mass public level. Okay.
So what has happened for India, I'll discuss. Our Prime Minister announced that each and every one should be wearing a mask in this current scenario, and people really listen to him. And that's something which has worked wonders for us, because now any patient who's coming into the hospital is actually wearing a mask. And even if they're not wearing a mask, the hospital is also providing them with masks so that they can actually safeguard themselves. So it's not just PPE. We can't afford PPEs for everyone in the population of 1.3 billion. But at least a mask is something that can actually help us in controlling. And that's something that is happening in our country.
So I'll give you a very clear example. In our clinic, we are not offering PPE to patients. They bring their own if they want to. But obviously, because we are triaging them, we're kind of essentially classifying that they are symptom free, or they are classifying themselves as symptom free.
Because
So
when I was going through the document, there was a section whether they when they asked you whether you're providing PPE to the patients or not.
and we're not in our clinic. We're not. And again, this is all additional layers of cost, etc., etc.
Exactly.
Not only are clinics and patients faced with the extra testing costs, and now at every level we have a lot more cost to deal with PPE and so on. So again, we don't want a system to be cumbersome whereby people just say, you know what, this is just over the top and I'm not going to do anything.
Yeah.
You'd rather have people doing things which are manageable rather than someone saying, you know what, we're just not going to do this because this is not doable. So moving on. Yeah, sorry.
Yeah, and that's where I think your consent is something which is easily manageable. It's just one piece of extra document that you have to sign. But what I want to tell here is that make it as elaborate as possible.
Yeah.
So, and like tell them about all the risks that are associated, so that you can actually streamline all of these processes in the near future.
Absolutely. Yeah. There's some more questions that are coming up. One of the questions I'm reading here is maybe you want to filter the patients or filter the questions, or
it should be on your screen right now.
Yeah. For onco patients, do we still progress with IVF with new guidelines? Yes. So Nantara, the guidelines in the UK allow clinics to proceed to egg collection for oncology and OHSS patients, even if they are positive. But you have to then freeze the embryos. And the next question you're asking is, do you keep them separately in the tank? If you do have a separate tank, then yes, by all means. But otherwise, if you don't, then you use a closed vitrification system to minimize the risk of cross transmission.
Yeah, and I think this is one technology which will really benefit. Like India, I think closed systems are not as popular as in the Western world, only because of the ease of use of open systems. But I think if you look at the future, probably closed systems is something that we all have to now adapt to, especially for such cases.
Mm-hmm. So then if we move on, we say that are the patients aware that if the treatment cycle starts, it can be terminated if they encounter a situation which places them at high risk. So you need to make your patients aware at the initial consultation about that. And of course, the
Yeah.
consent should also capture that. So we can move further down into that document. And again, this talks about financial implications. If their cycle gets cancelled, they obviously lose a certain portion depending on what your refund criteria is in your clinic. Have you got patient support policy to outline how you will ensure patients can receive appropriate support during this time? And again, you may want to develop patient support groups or counseling around this. The code of conduct, and again, happy to share that document,
That'll be great.
because it is something that, we are making sure that we have our staff and our patients sign.
Okay.
So we are definitely having a document called the Code of Conduct, whereby patients are also signing to say that they're going to minimize their exposure externally out of the clinic. We're not saying that you totally self-isolate for 14 days, but certainly you need to minimize the risk. And so do staff, because ultimately we have a responsibility of care towards each other, whether that's a patient to the staff or that's staff to the patient.
Yeah. Again, so when we're talking about cancellations, are these cycles funded by NHS, or are the patients paying from
Not
their
in
own
our
pocket?
clinic. We're not a clinic that has any NHS contracts. All of
All
our
right.
patients are self-paying.
And then you've also worked on a refund policy for all of these patients, etc. So that
Yeah.
I think that's also something that we also now have to consider. If we undergo cycle cancellation, we have to make refund policies for our patients, especially if they have COVID, because otherwise I think legal issues might follow.
Exactly. And not necessarily only if they have COVID, if they're symptomatic as well, because the UK guideline is strict enough saying that even if they're symptomatic.
Okay.
So, the clinic then takes it onto themselves. Staff and patient triage. Now, you guys have probably all seen the ESHRE triage document. I think it's very good and it's very comprehensive and it covers staff and patients. So as not to reinvent the wheel, I would suggest just use the ESHRE triage document
Yeah.
for triaging. Screening as well, depending on what screening methods are available in your country, whether you have the RT-PCR or whether you have the IgG, IgM. As I said, we are using a dual system in the UK. We do not have a reliable IgM test. So we're just using an IgG test to firstly see if the patient has any antibodies. And if they do obviously have antibodies, then they have been exposed to the virus and have immunity. But if they do not have IgG antibodies, then we will do the PCR test on them to see if they have any active infection.
Yeah. And if you go through the ESHRE guidelines, I think if a person is asymptomatic, I think no one is recommending a test for the staff at the moment. Is that right?
So in our clinic, again, every clinic has to make its own guidelines and decisions. In
Okay.
our clinic, the return to work conditions are that staff do get tested.
Okay. Okay. But then how many times will you test that staff
Correct.
then?
What we are doing is, well, in theory, your test is only valid for that day.
Exactly.
In theory.
Exactly.
So again, what we're doing, we need to have some benchmark, you see.
Yeah.
So what we're doing is we're testing just to see that their fitness to return to work. And
Yeah.
then we are triaging staff every week.
Every week. Okay.
Triaging,
Triage. Okay.
triaging, not testing, triaging.
Yeah. Okay. Makes sense. But
And
the kind of
if
guideline.
If they triage positive, then they get retested.
Okay. The kind of guidelines that I was going through, I think all of them mentioned that uh, if the person is asymptomatic, there is no problem in getting them back to work. And only when they start showing mild symptoms or they are symptomatic, that's when the test is advisable. In our country, I think the tests are also limited. So probably that's a scenario which we might have to follow. We might not be able to test anyone and everyone. But yeah,
But
good to
let's
have you.
not forget, Keshav, that 20% of your population, which includes staff, are asymptomatic infectious.
That's true. That's true.
So
And
someone
that,
could triage negative throughout the questionnaire and yet could be infectious.
yeah. And that is where, like, you will have to now start taking all kinds of precautions in the laboratory, because anyone can be asymptomatic carriers or asymptomatic infectious carriers, and they should be provided with all the best kind of PPEs that you have. So don't restrict the access of PPE for your staff, and try and mitigate the risk as much as possible. If a test is available, that's the best, but we have to consider how many times can we actually test that patient. And testing once and then triaging after that is also a very good way of handling things for the future, which Alpesh is following.
There's some questions that have come up. I don't know. Do you want to take any of them?
Okay, so Niharika here is asking a question. So this is from our laboratory itself. We're located on the fourth floor, and if you plan a triage, we do a thermal check at the entry of the floor or at the entry of the clinic. Where would you want to do that? And again, the patient can be anywhere in the hospital, can be in the cafe, can be in the canteen, etc., etc. So it can come in contact with anyone. I think if I want to answer the question here, the first triage has to happen at the entry of the building, and that's where your patients should get segregated. But if you want to
Before that, sorry, Keshav, it needs to be before, because
yeah,
what you can't do is expose that patient to anyone.
yeah,
So, in theory, an untriaged patient cannot even enter the premises. So, the telephone triage is a very good way to do things
yeah,
remotely at the
that's a
first.
fantastic idea. And I love this idea, Niharika. I think we have to now start working on doing electronic triage or telephonic triage for our patients. A wonderful idea which Alpesh has brought through here.
Yeah.
Yeah.
Okay. So if we, yeah, sorry, how frequently do you screen for COVID in a patient? Like when patient comes in for down regulation, do you do a test and do you repeat the test later on? So Niharika, what we do in our clinic, and again, protocols are very variable between different clinics in the UK, because testing is not mandatory. As far as the HFEA guidelines are concerned, they are not saying you have to test. They are saying what is your clinic criteria to minimize or offer safe care during the COVID. So testing is purely a clinic specific protocol. So what we have done, I know some clinics are only testing once. We have decided to test twice. Now what we're doing is we're testing the patient when they are in a what we call cycle before starting the cycle, and we're starting off with a check then, and then we are doing a PCR test during their stimulation as well.
So Reena is also joining us from the UK, and she's actually commented here that UK NHS clinics, asymptomatic patients have to undergo COVID PCR at least 1 to 2 days before HCG. If
Yeah,
positive, cancel. That's what we discussed. And if negative, we repeat a test after egg collection and before ET as well. So,
that's
so
great.
that's
Yeah,
what the NHS is doing
this is
at
great
the
because
moment.
it's really a very robust system, because you are picking up those kind of you're picking infections typically quite frequently after the egg collection, or at least after trigger, which is great.
Yeah. So moving forward, do you want to discuss the questionnaire a bit and then take on questions?
Yeah,
Even on
let's head through the document, because I think we have limited time. Um, so will staff that are suspected of infection be referred? Sorry, we can
sorry.
stop there. Yeah, so again, in the UK, we have to make sure that we're still offering a lot of our staff the ability to work from home. Again, we are very, staff are very protected in this country. There's a lot of rights that go with employee staff, and of course, rightfully so. So if there's anything that can be done digitally whilst whilst a member of staff who is more susceptible potentially, say if someone's asthmatic and they're more susceptible to it, then clinics or their workplace is supposed to make their possibility to work from home, especially doing nurse consultations or history taking, etc., etc. So this is just testing, this is just saying that whether you're providing all that, in fact, we referred for testing. And again, whether the clinic is offering their staff to be tested as well. And again, we as a clinic are.
Any
Yeah.
other modality for screening other than IgG? Now, Dr. Sanjay here is asking if you can use the PO2 levels as a screening method. I'm sure that's not the best scenario. It's not conclusive. But are there any other modalities apart from this?
No, Sanjay, I mean, I haven't heard of this testing. Maybe I just, maybe because all the discussion in the UK has been around IgG, IgM, and PCR. I haven't heard about the
Yeah.
oxygen testing at all. But again, I think I agree with you that it could be very, very subjective, very superficial. It would rely highly on calibrated meters as well. So I'm not sure how accurately we can
And
do.
there could be many other multiple disorders where you can have a low saturation, and I think this would not be a reliable modality for screening. But then it can help you in picking up people who are susceptible, and then you can offer them a test. So I get his point there, but I don't think we can do this for the masses at the moment.
Yeah. There's a question on my screen which is saying if a patient visiting our clinic is positive, do we cancel stimulation for the rest of the patients since they will be quarantined? No, so we wouldn't do that. Of course, you as a clinic may want to firstly develop social distancing measures that you may not want more than X number of patients in your clinic. And again, because you're going to be testing, if you're going to be testing all your patients, then essentially you are covering yourself to find out if that patient has been infected. So I think it would be too much of a radical approach to cancel all the other patients who may not be positive.
Yeah. So again, I'm going to break here. Jasneet, this is a very good question, and I want to ask Alpesh's views on batch IVF in this scenario now, because we know that a lot of Indian clinics practice batch IVF where they're doing so many cases in one day, and even if you follow the correct guideline where they say that 1.5 hours of difference duration should be maintained between patients, do you think that batch IVF will no longer exist in the country for the moment? Or
Well, I think from a risk assessment perspective, you're adding a lot more risk to that whole process if you're batching patients. We're actually trying to go the other way around, whereby we're trying to develop wait lists on patients who we're starting. So,
okay,
there's some patients who we will make sure we put them on the long protocol. Agreeably, it may not be the best thing for them, but because you want the ability to program their cycles, or you put them on the oral contraceptive pill, etc., etc. Simply because you want to regulate the amount of activity you do. So doing batch IVF is trying to contradict that,
exactly.
because you really need to minimize the amount of activity that the clinic can potentially do with the size of the clinic, with the equipment that the clinic has, and most importantly, the staff members that the clinic has. Because also, I mentioned last time that clinics are expected to work in shifts to make sure that if you're a clinic that does, say, 15 egg collections a day, then you may want to do some egg collections in the evening and some in the
Yeah.
morning because you need to keep your social distancing up.
So when we're talking about this distancing between patients, 1.5 hours is what we're suggesting
Uh,
between pickup.
Sorry, Sanjay. Yeah, we are keeping 1.5 hours to 2 hours between egg collections.
Okay.
But
And
we're a small clinic, so it doesn't impact us that much. At the
yeah.
most, we may have 3, 4 egg collections in a day, and we can easily keep that spacing. But I know that even in very busy clinics, they're at least keeping 1.5 hours.
And what happens in that 1.5 hours? Do we have to disinfect everything after each patient?
After each patient, the theater has to be disinfected and the recovery bed, etc., has to be disinfected. And of course, in the UK, we have our risk assessment has been taken to the level that even in your recovery, do you have air handling units that are exchanging and filtering air? Because that can also affect how long those virus particles or those viruses hang around in the air. So if
Yeah,
you're going to say, we're going to do every half an hour, is the virus still lingering around in the air till the
yeah.
next patient comes in? We don't know. We don't know what the golden answer is, Keshav, whether it's 15 minutes, whether it's 50 minutes, whether it's 90 minutes. It's
We have
just
no
an
clue.
arbitrary
That's
number.
true. We have no clue. But when we talk about like certain things that can be incorporated, do you think that those plasma filters or the newer air filters with like UV in it, etc., would be eradicating the virus, or that's also something of a gimmick? Or
Well,
uh,
certainly from a lab perspective, and I think we should really focus our kind of discussion more on the lab bits because there's a forum of embryologists here. We discussed last time, we discussed the air filters, the AHU, and as much as, there's so much out there that we think eradicates a lot of these bacterial or viral contaminants, but the key question is, does it do that?
does it
So
do?
likewise, the use of UV in your flow hoods, it's there, and if it's there, then use it. I wouldn't go and start buying UV lamps just to kind of keep in my lab overnight. Essentially, there is nothing better than good disinfection because we know for a fact, Keshav, that works.
That's true.
So if you have good disinfection, regular disinfection protocols, good sanitation, good hand hygiene, good social distancing, good awareness amongst your embryologists about PPE, then all these things are going to surely minimize the risk.
And we've discussed in detail about disinfection in the previous live stream that we did, which is available on this page. So if anyone's interested, I think we don't have the time to discuss it today. We might touch upon it later. But if anyone is interested, they can go back and see the recording of the one. So we have a question here. When discussing testing before HCG or after pickup, are you testing both partners?
Answer
So
is before we are not doing any kind of testing after egg collection. But again, this is a very, as I said, very clinic specific protocol.
yeah.
Our test is going to be done on day 10 of stimulation. And if they are obviously positive, then at some we would cancel it. If they turn positive between trigger and egg collection, then we would freeze their embryos. But the testing is done on both the partners, on both patient and partner.
Patient and partner, but probably after the ovum pickup is done, and then you will test. If your policy is to test before ET again, then if the male partner is not coming into the laboratory and only
But
the wife comes, you
it's
can
not only
restrict the
that now, Keshav, it's also the woman is most exposed to that man.
That's true. That's true. So maybe you have to test both patients at both the specific points. Reena has a comment here, and I'm just going to add that she's saying that NHS divides into red, green, and red is obviously COVID, and green is the non-COVID patients, and there is a proper segregation here. But what do we do in units, especially which are now in hospitals? Now, I understand if you have a standalone center, this can be better controlled. But if the unit is already in a hospital where multiple patients are coming up, how do you segregate, or do you have like a separate timing for IVF patients, or do you have a separate entrance? This is something that would be problematic in these scenarios.
And I think it's a very valid question you're asking, Keshav, because in India, IVF units are potentially part of larger hospital institutions as well. So I'm sure you would really need to agree with your hospital management guidelines in
Yeah.
terms of how this can be managed. And I think Reena's input is very valuable because she works at an NHS
That's true.
establishment. I think it's very reassuring to see how the NHS clinics are, which are sometimes part of a multidisciplinary medical care facility are segregating these systems. But it's great to hear that they have really, they're ahead of the game.
Yeah, we have another question by Sudesh Kamath here. If you're treating a patient who's positive, maybe during OPU, won't all the staff who's actually been in contact with the patient undergo the test and be quarantined?
Okay, so you see, there is also something, quarantine. Yes, hypothetically, the risk. Yes, you've been exposed to someone who is positive. You could be testing someone till the cows come home, because you don't know whether today they'll be positive or after 10 days they will be positive. When is the right time to do the test? Of course, if someone is positive, then we know what we're supposed to do in the lab. But the question here is asking, what do doctors have to do? Now, what I suggest we do, that when you know that you are testing someone who is positive and has not yet had an egg collection, then you need to wear all your PPE as if you are treating an infected patient. And what it says, that if someone is wearing full PPE, then they are not potentially at that level of risk.
Yeah.
So then they can carry on things as normal. It's like, Keshav, it's like, there are thousands of doctors who are working in the NHS, working with COVID positive patients. They're not allowed to go home and self-isolate.
Exactly.
They're supposed to wear PPE.
If you're wearing PPE, and the patient is also wearing protective gear like a mask, etc., then the risk of transmission is less than 1%, is what I've read.
So regular triaging is important. So to answer Sudesh's question, regular triaging is important of your staff. And of course, personal protective equipment, because that's the only boxes you can tick to say that you have done something as per your SOP.
Yeah, and if you've come in contact with a patient and you feel that you've not taken the proper precautions, then get a test done and be sure of like a negative report.
Yeah, absolutely. Okay, so unfortunately, we're not even halfway through this document.
We have questions here today.
Okay, well, I'm happy to do whatever. If you want to answer the questions, we can answer the questions.
I think we should do the questions. I think we should do the questions first.
Let's do the questions. Yeah.
And then we have time. Yeah.
We have not completed.
So
in Kerala, is there any ET, especially should pregnancy be deferred? Again, in the UK, Sonu, there is no specific instructions to say that we should not be doing embryo transfers. The guidelines suggest that if the patient is asymptomatic or non-symptomatic, you treat them as if you would normally. So you go up to the point of embryo transfer. Absolutely. There's nothing suggesting that we should only be freezing embryos in this time period.
But Sonu, you should also now look at your local guidelines. I'm not sure what's happening in Kerala at the moment, but I know that in UP, our chief minister has advised that all non-emergency procedures be avoided if possible. So again, these are things that you have to now refer to your state guidelines and your country guidelines.
Because that's true, isn't it? Because even in India, Keshav, there is different parts of India that have different guidelines about IVF.
Exactly.
Okay, wow.
Okay, so Sarabpreet is here and he's asking what happens to the IVF lab and OT then? I think he's referring to our discussion of when a positive patient comes in and how to disinfect, etc.
So deep cleaning is important. I mentioned the hydrogen peroxide bomb last time, and I appreciate that this may be something which may not be available in India. But we have certainly spoken to our cleaning companies, and they have got these specialized steam cleaners now, specific during this whole COVID pandemic. So I know for a fact, and I've asked them this question, that at short notice, if we have to get you in to do this level of deep cleaning, would you be able to do that? And you have to have that contingency with them, that in the event you find out someone is positive, then in theory, you have to undergo a whole deep clean of your operating theater and of course, your laboratory as well. I appreciate that embryologists keep the laboratory side of things pretty clean, and I wouldn't be too concerned about a deep clean. But again, I don't want to kind of generically make that statement, because even environmental conditions are very different in different parts of the world in terms of
Yeah.
contamination. So my responsible answer to give is try and do a deep clean before your next case.
And what about your collection rooms, Alpesh? Same kind of protocols in between collections as well,
So
semen collection.
as I said previously in my last interaction, we are advising people to produce semen samples at home.
Okay, but if that is not possible,
Then again, you need to have a very thorough cleaning regime of your semen production rooms, because these are very high risk areas, and we
and
know for a fact that the receptors are there even in semen.
and again, proper spacing is something that we will advise for collection as well.
Hopefully, we will not put multiple men in the same room the same time. So, no, definitely the protocol of cleaning. I mean, the good thing in India is, and again, I'm not saying, I would say that whilst clinics have a specific cleaning department that comes and cleans, you may want to look into the frequency of those cleans. And even in the UK, we clean the semen production room in between every patient. But again, we're talking about another level of cleaning here.
Another level of cleaning. That's true. So again, probably the same kind of spacing that you're doing for pickups, the same kind of disinfectants that you're using for your OT as well as your laboratory, and that should probably suffice in this scenario.
And yes, I must add that I think this is this can be argued, because I have chosen to ask my patients to produce at home. Whereas yesterday, Ashok Agarwal and I were talking in a webinar whereby he said, well, he would be concerned about the risk of infection or contamination when men are allowed to produce at home. So all these things have to be taken into account. I agree.
Yeah. So now we've talked about the female partner testing positive, but what happens in the scenario where the male has tested positive and the female is not positive? Egg freezing, or you still can?
No, because in theory we don't know if this can, if now there are receptors on the embryo.
Yeah.
We don't. So if, well, again, there's so little known. But if either of them are positive, then we are freezing embryos.
Okay. No, but are we making embryos in this scenario if it's happening before pickup, where only the male partner is positive?
I see. It's a very good question, Samia. I didn't think that through. I get it now. Yes, but potentially consider egg freezing.
Yeah. So Samya, egg freezing can be advised in such a scenario, and but do make sure that you have the documentation that the female has tested negative. And again, I would recommend doing this in a closed system because in India, the efficacy of these tests also is something that is worrisome. Patients are actually testing negative and then testing positive, so we don't know. So again, in such scenarios, probably a closed system is something that I would recommend or add on to such a scenario.
Okay.
Yeah. So we have more questions. Is cleaning with USAFE only sufficient, or is there anything else that's needed?
I think obviously as embryologists, we are quite cautious about what we can use in our lab. And USAFE is definitely shown to be active against the COVID-19 virus. I think it's within, I don't know, 30 seconds or 60 seconds, I don't know what it is. But it definitely is shown to be effective. I would be quite concerned about using sodium hypochlorite in a lab setting because of the whole smell around it. Maybe sodium hypochlorite can be used in other parts of the clinic, like reception or your consulting rooms, or even your recovery area. But I would prefer not to use it in theater and lab.
Yeah. And again, like if you're managing your lab and your staff properly, if you're maintaining distancing, if you have minimum staff entering into the laboratory, I think you will be looking after a lot of the complications of transmission by just doing that. And I think in those scenarios, USAFE, the floor cleaners, and not just USAFE, we're not going to be biased. There are other disinfectants which are IVF grade as well, which have shown to be efficacious in treating, in actually decontaminating COVID. So any of those can be utilized, and just follow the exact timelines that are there, because we
Hmm.
know for a fact that with USAFE, at least 60 seconds of exposure for viruses, about 5 minutes for funguses, etc., is recommended. So do follow the correct protocols.
Sure. There's a question here. What about semen processing in the lab? As there are receptors in semen, should we wear PPE to protect ourselves during the processing? So the standard PPE, Minakshi, is that embryologists should wear scrubs, they should wear a mask, they should wear a hat, and they should wear gloves. And of
Yeah.
course, it's universal protocol now that when you're handling semen, you should be wearing gloves. And I know in some labs they don't wear gloves during egg collections or embryo manipulations, but certainly I would say that with semen there is no exceptions here. So also another thing I want to mention, that please check that the flow cabinets that you use or your laminar cabinets you use have to be class 2, because if they are class 2 they are protecting the operator and the sample. As far as I know, a lot of the class 2, well, a lot of the flow cabinets in India are class 1. They're not class 2 because they don't have a screen that
Screen
is
over.
literally to the height of your chest.
Yeah.
Here, the flow cabinets we use, we have eyepieces coming out of this plastic perspex shield. So that's why it protects the operator and the sample. So if you have the correct equipment, such as your laminar class 2 cabinets, provided you're wearing the right PPE, and most importantly, yesterday we talked about which method of sperm processing. At this point in time, I think the consensus is to not to use the swim up method, but to try and use the density gradient so that the viruses can potentially also be trapped between the layers of the gradient.
Okay, so I think this answers the next question by Samya as well, which is talking about processing itself and what kind of methods to use. So maybe density gradient is something that's recommended. What's your take on doing a swim up after density gradient to be like very sure? The standard procedure that we probably do for HIV
Hmm.
is density followed by swim up. What's your take on that?
I would think that's fine, because essentially if you've done the density gradient, that is the main area that you may have eradicated a lot of the bacterial contamination and the viral contaminations. So
Yeah.
you could potentially do a swim up. Also considering that in India, majority of the cycles are ICSI and not necessarily IVF. So
Yeah.
anyway, whatever you do, you are greatly minimizing your bioburden by doing ICSI
By
anyway.
doing. Yeah, this is what we were trying to talk about last time as well, where obviously there are no specific recommendations at the moment whether to go ahead and do IVF or ICSI, but maybe by doing ICSI we might be
It's not
minimizing.
our
We're
default.
not sure.
Based on your clinic protocols, we might be minimizing it anyway.
True. All right, so we can go back to the document, and all the viewers here, we still have about 5 minutes. We can ask a few questions if possible. Alpesh, what's the most important part that you want to refer to?
Okay, so let's go down, because this is all been just again. Can I just have that question minimized so I can see the screen? Samia's question is still
For one
shown
second.
on the screen.
All
Huh.
right.
Okay. So this is again talking about operational aspects and how clinically, whether you have a clinical SOP that you're going to be using during the COVID pandemic, whether
Yeah.
you have a lab SOP, how you're minimizing risk to staff as well working in the lab. Have you made arrangements to restrict access to the clinic? Again, yes, your social distancing protocols, arrival time, check-in time. Ask your patients to wait in the car if your patient is still in the clinic. So we ask our patients if there is delays. And again, I mean, we know doctors are quite notorious for this. And, there could be delays just because, patient X takes longer.
Yeah,
So
that's
we
true.
ask our patients to wait in the car, and they will only come up when we call them to come in. And we have a parking area here so they can sit in the car and wait.
Okay.
We can move below 29. Do you have SOPs, risk assessments in place? Yeah. Let's move. Okay, that's it. Yeah. Do you have business? Okay, this is not really, this is just asking about business continuity plans. Let's wait there. infection control. This is quite important. So again, you have to have a very robust infection control policy whereby you can demonstrate that your facilities are adequately cleanable. We know that in clinical settings you can't have carpets and things like that. And again, especially in this pandemic, because this could be harboring a lot more. So try and bump up your infection control procedures as well, or policies. There's a question that's come up. Consent form, do we require to check? Yes, Pooja, the consent form has to be a very specific one. And in the UK, we have been recommended to develop a COVID-specific consent form for our patients, and we have done that. So again, I'd be happy to share any of that with Keshav. And,
Alpesh, if you can share them with me, I can put it on the comment box here once this is over, and so that everyone can have, whoever sees this can have access to those documents and actually can prepare themselves.
Okay. Okay, so moving on, if a patient suspected positive after collection, do you have procedures in place to consider whether a freehold is done? Yes. I think a lot of these questions are very straightforward based on the conversations we've already had. Have you taken precautions in the laboratory to reduce exposure to the virus, including the type of workstations? Again, this is asking about the workstations, right? So I have also said that if you do use those, what do you call, physiological chambers or your IVF chambers and things like that, try and minimize exposure. We've talked about last time to try and use time-lapse systems a bit more. But again, risk assess, because if someone is positive, they can't go in the time-lapse system because that's a shared incubator. So
there was a question, I think before this, how would you review your witnessing protocols in such a scenario?
Okay, so again, if you have electronic witnessing, then you're in a very safe zone here anyway. If you do not have an electronic witnessing facility in your clinic or equipment, then you really need to kind of risk assess the distancing, how you're going to keep social distancing measures intricate. So what we do is, I don't have electronic witnessing in my lab. I have manual witnessing, but I will make sure that I literally step after I've done a procedure. Say if we're talking about semen prep, I do the whole semen prep. I keep all my containers from pot to tube 1 to tube 2. And that's, once I've finished with that, I keep everything there. I take a step back. My colleague comes in and she witnesses everything and signs it off. So that's how we kind of maintain the social distancing and yet continue with the witnessing.
I think we'll do this number 47, and then we can close the document and answer a few questions.
Will you consider delaying starting treatment for high-risk patients? Yes. So again, this is a guideline by the HFEA that they are suggesting, or even in ESHRE, I believe it's a guideline that if people who are at high risk do get, deferred treatment, unless obviously they are at a severe risk of losing their fertility. So if a woman has got an AMH of 1 or 2, then you may take a call that you will treat her. But of course, they are immunocompromised patients in this time period who, if they develop the virus, are more susceptible and vulnerable to health conditions. So again, one of the things that the HFEA has been quite clever in asking is that are clinics going to be using immunosuppressants as part of their IVF? So we know people use prednisones and intralipids and things like that. So again, it needs to be re-evaluated that whether in this time period, in this scenario, it's worth using those immunosuppressants. Luckily, we as a clinic don't use them. So
that's something I didn't think about. So another good point by this discussion here. So let me just put in a few questions. Sanjay is asking if you can share the documents. Sanjay, सारे भेज दो. No, but we'll be helping you.
क्या दोगे मुझे?
No, but I'm sure I'm here to help all of us out. And we will be sharing the consent, and I'm going to put it here. So
I will share my documents. I'm very happy to share anything that I have. So yeah, please just ask.
Okay. Nentara has a question here. Normally we perform ICSI. How is the manipulator taken care of then?
Again, there is nothing specific like autoclaving your micro manipulator. You just have to use disinfection
Yeah.
in between patients. Make sure you clean your tool holders quite well, Nantara, because this is where there could be an entry if you've taken your oil too high up, or if you've taken your media or PVP too high up, then that's where potentially the virus could be. So please pay a lot more attention to those intricate parts of the micro manipulator. Don't
And
worry too much about the lens and the joysticks and everything. Look at what's really in contact with the egg and the sperm.
and if you are multiple users in the lab, if you are
Try and minimize that. Try and make sure that in one day, one person does the ICSI.
yeah,
Don't try and let multiple people sit on the micro manipulator.
not advisable.
By the end of the day, you just clean the chairs and everything, of course, your tables and desks.
Last few questions here. Rahul is here. Any specific precautions while discarding biological material?
Yes, there is guidance around this, and the guidance is around this dilution. So, with semen samples, they're asking for it to be diluted with water. You may want to totally disinfect it. So, some people are taking the view of adding safe spray to it and then discarding. Some people are saying 70% ethanol. I never use 70% ethanol in my lab. Some people just use water to reduce the bioburden. And of course, you have to discard in clinical waste bags. That goes without saying. But also try and make sure that you have regular changes of these bags. In the UK, we dispose them daily. So however full they are, however less filled they are, we still dispose them daily. So
Okay.
review those SOPs as well.
All right. So thank you everyone for coming to this live stream. We've had a good discussion today. Alpesh, your take-home messages for the viewers here.
Um, it's not impossible to start. My take-home message is that yes, this has really given us this whole pandemic has given us a lot of food of thought in terms of what are the best practices around IVF labs. And we've also been fortunate that whilst there's been a lockdown, in a way, the good thing, Keshav, has been that we have been in a lockdown and embryologists have had the opportunity to listen to so much material around
Yes.
how to change their practices. And I think that's been a great thing and a learning objective. Now, the take home message is disinfection, PPE, make sure that testing is available. Protection should not just be your patients, it should also be your staff. So try and safeguard as much as you can. And ultimately, you can only do what is in your capacity to do, right?
That's
So try and incorporate the best guidelines. Try and don't ignore these guidelines, please. The virus affects everyone, so it would be very irresponsible, in my opinion, to go back to work and do everything how we used to, because there is a new way, there is a new norm with how we should be working in an IVF laboratory.
Yeah, I agree with you. And my take-home message for all of you at this moment is we have the time. We are still under lockdown. We can easily make our SOPs in place. We can put them in place. And so that once we get back to practice, we follow a regulated manner of approaching these new patients that will come up. And this will be the new normal for all of us. And this is something that we have to do. So please utilize your time in this current period to write those SOPs. Alpesh is there to help us out. But do that exercise, and I'm sure that's going to help you the most.
But please don't send me your SOPs to review. I won't be able to do that. But as a kind of I'm happy to share any of my documentation if you need.
That'll be great. Thank you so much, Alpesh, for joining us, and thank you for this wonderful, informative session. Lots of good comments here on this session, so I'm sure we'll be doing this more often. You're going to be a little busy now because the lab has started, but we are free.
There's been a bit of like floodgates open up, I must say, because our phone lines have just been inundated, and I'm just expecting a huge wave. But we'll manage it. And as I said, we have procedures in place. We have preempted these situations. We have got wait lists. We're going to make sure that we're going to be fair in how we bring patients through. We're going to be safe and we're going to be effective. Those are the key things. Patients want to know that they can be treated safely. I'm sure patients don't mind waiting 2-3 weeks if they have to for their first consultation. But let's just do things which are best practices and the safest practices.
Last question, when next?
When next? I don't know. Jab aap bulaye.
So I'll be troubling you more, and hopefully we can come up with a date, and we'll appraise all of you with whatever schedule that we come up with. So thank you so much, and thank you all for joining. Thanks, Alpesh, once again, and best of luck for starting again.
Pleasure. Thank you so much. Everyone keep safe, keep well, and lovely to see so many of you tune in. I know some wonderful people who I've met and who are good friends of mine. Goral, hi, nice to meet you. Manisha, wow, how are you? So lovely to meet you all. Thank you so much for listening and tuning in. And till next time, take care, look after yourself.
Okay, bye-bye, good night.
All right.